and thank you everybody for attending this seminar in which we are going to review the data concerning the cardiovascular risk associated with hormone therapy, in which we are going to present the recent studies concerning the help that we obtain from biomarkers to give support to the window hypothesis. For that, we will follow three main steps. This is something that I should say will take us something like some 25-30 minutes in total. And as I say, the three main areas that we will review will be first, estrogens and vascular wall as a context and the window hypothesis, in which we will present the data derived from the WHI study. Then we will move to the second point, in which we will present the values brought by the use of new biomarkers concerning the assessment of atherosclerosis. And for that, we will review both imaging and clinical biomarkers. Essentially, I may already tell you that the clinical biomarkers will be hot flashes. And then, as a third point, we will review further studies relating everything with the exposure to estrogens. So this is data that we have learned from several years ago. Actually, these are papers published, as you see, in 2003, and both of them. And they all present the cardiovascular data obtained in the WHI study. On the left, you have data concerning coronary heart disease, in which is clearly shown that women subjected to estrogen plus progestin, which is this blue line, as compared with women receiving placebo, which is the yellow line, show a difference concerning the risk for coronary heart disease. So you have here the figures in which it's clear that women, as I say, subjected to hormone therapy were presenting a higher risk or higher number of events of coronary heart disease. And this is something similar to what was found for stroke. Here you see that there are a small difference at the beginning, but then again placebo, which is the bold line, versus estrogen plus progestin, which is the other line, in which there is clearly also a difference between those receiving estrogen plus progestin, showing that the use of hormone therapy might be associated with an increased risk for cardiovascular disease, both in the form of coronary heart disease or stroke. But this is a paper which was published a few years later, and actually you have here the reference, it was in 2007, which was a reanalysis of data in which women participating in the WHI were all pulled together, both arms. Remember that one of the studies include women receiving estrogens plus progestin, women with a uterus, and hysterectomized women were receiving only estrogen or placebo. They were all pulled together, as I said, and they were stratified, as shown here, in three main columns. On the left, you have women who had suffered menopause less than 10 years ago. In the middle, those between 10 and 19 years since menopause, and those with more than 20 years since menopause were here on the right column. And as shown here, you see that the hazard ratio for coronary heart disease, stroke, total mortality, and global index, for those who were younger and those who had suffered menopause more recently, the ratio was different to what was found for those who had their menopause much earlier. So it's clear that, for example, if we look at data concerning coronary heart disease, here is shown, as I said, that the hazard ratio was lower than 1 for those receiving hormone therapy, implying that those women were at lower risk for coronary heart disease. I am aware that the confidence intervals include 1, and so it cannot be exactly concluded. But it's also true that when examining, as shown here, the three groups together, the trend was significant. The p-value for the trend here is lower than 0.05, suggesting that probably there was an issue concerning the number of years since menopause. This was the basis for proposing the window hypothesis. Window hypothesis, which was trying to reconcile what we had learned about the action of estrogens on the vascular wall. This is clearly shown in this slide, which this is a very classical study from Mendelssohn and Caras, which was published in New England Journal of Medicine already in 1999. So it's pretty old but consistent data showing that estrogens have different actions at the vascular wall. There are rapid effects, non-genomic, which include the induction of dilatation or the production of nitric oxide, which we know that concerning or relating with the actual theories about the origin of atherosclerosis, we know that these changes, which are related with endothelial function, are very much important concerning the increase of risk for atherosclerosis. So this is important because from that point of view, estrogens might be acting on the initial steps concerning the development of atherosclerosis. And together with these rapid effects, there were also, and there is here plenty of experimental and clinical data as well, showing that the longer-term effects, the genomic effects, were related with atherosclerosis, reduction of atherosclerosis, reduction of vascular injury, increase of endothelial cell growth, still implying again that there was a promotion of endothelial health and also a reduction in the growth of a smooth muscle cell, something which is related with the development of atherosclerosis. So again, those data, the clinical data that we just reviewed in the previous slide, might have something to do with this older data, mostly experimental, which were also very clearly hypothesized and integrated by Thomas Clarkson, the group of Winston-Salem in the States, which produced a very important number of studies with monkeys, were able to show something which is actually, this is a slide which was prepared by him and which I think we have been using for years in different meetings and different speakers. So as shown here, this is at the top, the progression of atherosclerosis, the different phases of atherosclerosis in which we know that the initial manifestation is the fatty streak plaque, which, as I say, is something which relates very directly with the endothelial function. Progression involves the development of a thicker fibrous cap, also a thicker plaque, which at a certain moment here at the third phase includes the production of a necrotic core. Finally, the later stages involve a very thick plaque with a reduction, an important reduction of the arterial lumen and an increase of that necrotic core. This is very important because the rupture of these plaques involves an induction of the platelet aggregation and also the creation of a clot, which involves distal ischemia and the events, the clinical events that we know, either myocardial infarction, either stroke at the level of the brain vessels. And again, here in this left column, we have group, and we have all the estrogen effects in atherogenesis that we have known from clinical and experimental studies. We know, for example, that estrogens are related with a decrease in LDL oxidation, implying a reduction in LDL atherogenicity, also a reduction in LDL binding accumulation, therefore a reduction in lesion progression, a reduction in cell addition molecules, a reduction as well in smooth muscle cell proliferation, an increase in endothelial function, altogether suggesting a protection against the development of atherosclerosis. But on the right column here, we also know that estrogens might have a deleterious effect in those situations in which plaques are already well established. So we know that estrogens relate with an increase in inflammation, leading to instability of the plaques, also an increase in the expression of metalloproteinases, which are enzymes involved in the digestion of the fibrous cap, and therefore promoting also plaque instability, and also increase of neovascularization, promoting hemorrhage at the level of the plaque. Well, also lots of estrogen benefits, increase of methylation, and reduction of vascular responsibility. So we have here on the left the benefits of estrogens on atherosclerosis, and on the right the potentially adverse effects of estrogens on atherosclerosis and coronary heart disease. And also the same idea, but being shown in a different way here. Again, the 4 phases of atherosclerosis with the reduction, the progressive reduction in the lumen vessel, and also the percentages of the prevalence of those stages according to age. So it's 10% in women between 50 and 54 years, 20% in women between 55 and 59 years, and 45% in women with 60, 69 years, even considering also 70, 79 years, a total of 70%. So it's possible, and this was a little bit also the idea taken to support the window hypothesis, that because of women participating in the WHI study were with a mean age of almost 70 years, it might be that many of them were in that stage of advanced atherosclerosis in which estrogens might have a harmful effect. This is, as I said, the basis for the hypothesis, which has been further supported by new data. And then we take again our guide, in which now we are going to start the second point, which relates with the assessment of atherosclerosis by biomarkers, imaging, and clinical. I should say also, before going ahead, that it should be clear that concerning atherosclerosis, we have 2 different stages. One, which is represented by the risk factors, for example, hyperlipidemia. Hyperlipidemia is a risk factor for atherosclerosis, but biomarkers is already an indicator that the atherosclerosis disease, the plaques are already there. So this is a difference which should be underlined. And as I say, we are going now to review which tools we have concerning imaging, and also what we may learn from clinical data, and particularly, as I said, hot flashes. This is an ultrasound machine here on the left, as you see, and this is the picture we obtain when using high-frequency probes, which allow us to measure with very accurately, which is the thickness of the intima media at the wall. And particularly, it is used in the carotid artery, which is very superficial and very accessible to those probes. So we have the possibility of measuring, which is the increase of, which is the size actually of the intima media thickness, and also to have therefore an idea of whether there is already an increase suggesting atherosclerosis, or there is instead a situation in which it is not so thick. There are also automatic systems for these machines in which it is very easy with a special software to measure which is the thickness of the intima media thickness. Also, interestingly, we can observe or detect if there is some plaques, and we can measure the plaque. We can also identify, like here in this picture, if there is calcium at the level of the plaque, and also if the plaque is heterogeneous, showing those very plaques with different lucency are very helpful concerning the risk for having a clinical event. And the value of IMT, the intima media thickness, has been confirmed in different studies. For example, this is a study you have here, which is the details. This is a study in which almost 3,000 subjects, this is the Framingham offspring study cohort, were followed for some 7.2 years. And it's clear, you have here the clinical characteristic, clinical, analytical, and also the intima media thickness, which is here at the bottom. And it may be observed 2 columns here, those individuals that during the follow-up didn't develop cardiovascular disease, or those that developed any cardiovascular event at follow-up. And if we just go directly here at the bottom to the values obtained for the intima media thickness, it may be clearly shown that those on the right column are higher than those on the left column. And being so important, it was even more important what I mentioned about the detection of plaques, because this is the same study here, in which you see here there are 4 panels. Here on the panel A is shown any cardiovascular disease risk, low cardiovascular disease risk in panel B, intermediate or high cardiovascular disease risk here at D panel. And it's clearly shown that for any of the situations, those individuals in which a plaque was detected by ultrasound at the carotid, which is shown here by the blue line, have a fraction with a cardiovascular disease which was lower than those individuals without plaque. So again, it shows how useful these biomarkers, those systems that allow us to know directly that whether there is a detectable atherosclerosis disease already going on, so we may obtain conclusions, and we may, as is shown in this study, we may know how useful they are to identify and to help us concerning the risk for a cardiovascular event. And we also have other group of data in which we may directly explore the coronary tree. This is something which is done by a computed tomography. This is an angiography shown in this slide, in which you have here a coronary in which we may find, for example, the calcium deposits, which are here, also very clear in here, and also even clearer in this other more detailed picture. This is something which has been also completed by studies with magnetic resonance, in which together with the detection of calcium as shown previously, we may also have very good pictures concerning the narrowing of the arterial level, arterial lumen at the level of the coronary. Here you see, for example, a correspondence between, for example, here you see, which is the picture obtained in magnetic resonance, and which is the histological, the corresponding histological section for that image that was shown by magnetic resonance. So this is very helpful tools that may allow us to know a bit better, not only if there are changes at the level of risk factors, but whether there is already a disease which is at different stages, and therefore we may dig a bit deeper into which is the association, for example, of the use of hormone therapy concerning atherosclerosis. Again, and as we did for IMT, for intima media thickness, there are also data confirming how valuable this is the calcium score, the CAC, which is a score in which there are 4 levels established, one in which is the reference, which is no calcium score at all, and then a score between 100, 100, between 100 and 300, and more than 300. And in this study, in which what you see is a very study which a very high number of participants, 6,700 multiracial population, free of coronary heart disease at entry, and followed for almost 4 years. It was clearly shown that depending on how much the score of coronary calcium was, how high it was, and the difference concerning prognosis was also very different, and also the cumulative incidence of coronary events as shown here in the title of the y-axis. And also there are many other studies. I have just brought you this other picture obtained from the MSA, the multi-ethnic study of atherosclerosis, which is a big study involving also, again, almost 7,000 participants between 45 and 84 years, and which were followed for a median of 8.5 years. There are many data obtained from this study. I have just brought you specific data concerning women, for example, here on the left, or the association of those CAC, the coronary calcium accumulation, concerning the risk for coronary heart disease. If we check here on the left for women, we see how when they were stratified according to age between 45 and 54, 55 64, 65 74, 75 and 84. It's clearly shown that the low score for CAC, 0, which is blue, decreases when age increases. So as we all know, it's clear that age is a very important risk factor for atherosclerosis, and this is reproducing here, in which the higher the age, the higher the incidence, for example, of this CAC, which is higher than 100. And when considering all coronary heart disease events, it's also interesting because as shown here, again, the population is stratified according to age, and it's clearly shown that the association with risk is is very clearly associated with the score for calcium, because you see here the green bars are those associated, more clearly associated with risk across ages. So whichever the age, the high value of CAC is still important to associate with risk. So this is imaging, and let's move now to clinical parameters, and for that there is plenty of interesting studies recently concerning the value of hot flash, that very common manifestation of symptoms of menopausal women. So this is here just to remind you, this is a picture taken from this excellent study from study published last year in Climateric, in which is clearly shown which is the profile of a hot flash here. You have on A, the core body temperature, and according to that also the change of the respiratory exchange ratio, and also the change in skin temperature, which is plus or minus overlapping with that changes in the respiratory ratio. This is something we all know, but the interesting thing is that there is now evidence showing that hot flash might be an indicator of changes at the level of the vascular wall, and those changes might have something to do with different levels of risk concerning cardiovascular disease. And this is a story which started here. It started actually 30 years ago. It was published by this pioneering study by Professor Margaret Rees, which published this wonderful paper in which, with a very reduced number of women, she was able to show that the severity of hot flashes, subjective severity, because it was reported by women participating in the study, was clearly associated. You see here the increase in the size of the bars was associated, as I said, with a higher vascular reactivity. So it was something to do with the response of the vessel to ice in this case, which was different according to the presence of absence or the intensity of the hot flashes. This started in that work in Oxford, but more recently, and this is now a study from 2 years ago, it was shown that this is the SWAN study in the States, in which it was shown that that increased vascular activity may have a clinically detectable impact, and in this case is hypertension. You see here the hazard ratio for hypertension depending on the number of days of hot flashes. None, which is the reference, versus 1, 2, 5 days, 6 more days. You see that the increase in the prevalence or the intensity of hot flashes is associated with increased risk for hypertension, whichever the model, because this is unadjusted and then was adjustments for different risk factors. And again, it is reproduced at every model and with a very significant association. Again, important studies. This is a study from Professor Lambrinidaki in Athens, in which she was able to show here, again, with not such a high number of participants, but very clever study showing that with only 110 postmenopausal women between 45 and 55 years, she was measuring the IMT values. And again, it is not only hypertension as shown earlier in the SWAN or vascular activity as shown by Professor Rees. In this case is IMT, and it's clear that moving from none to mild to moderate to severe hot flashes, there is an increase in the intima media thickness, implying that it might be associated with an increase in cardiovascular risk. And this has been reproduced by other authors. For example, this is a study by Professor Thurston at Pittsburgh, in which the news concerning this study is that women, in this case 295 women, which were again studied concerning the IMT values and confronted with hot flashes frequency, which was stratified according to quartiles. And the news in this study, as I said, is that there are two types of information. One in which women were just reporting hot flashes, but also these women were wearing instrument, a device that was able to objectively measure the incidence and the severity and the duration of the hot flash. And interestingly, you see that how there is a very good relationship between that evaluation by the device and what was reported by women. And again, the higher the quartile, the higher the IMT, in this case, reproducing the data of the study that was published by Irene Lambrinidaki in Greece. And more, still more. Now we are not speaking only of indicators of biomarkers of atherosclerosis, but of real coronary heart disease events. This is an important study because you see the number of participants, 11,000, almost 12,000 women between 45 and 50 years, which were followed for 14 years in Australia. This is a study by the group of Professor Gita Mishra, in which, again, different models, different adjustments, but here in the left column, depending on the intensity and frequency of hot flashes, firstly, in the first half of the table, and then at the bottom, the night sweats, and again, never, rarely, sometimes, and often, the higher the impact of hot flash problem in women was associated here. You may just check any model 1, 2, 3, and 4, but it's clear that the reference, which is never, there is a progressive increase in the odds ratio for coronary heart disease when there is an increase in hot flashes, and this is all, in all cases, very significant. And if instead of hot flashes we assess night sweats, again, there is a corresponding response, again, very highly significant, whichever the model which was taken. And not only this study, there is also this other study, again, by the group of Professor Rebecca Thurston at Pittsburgh, in which there is a particular study. This is mortality in the WISE study. The WISE study is only enrolled women who were referred for angiography because of suspected myocardial ischemia. So this is not general population. There are women supposedly at higher risk, and this is why with this limited number of participants, that she was able to show that again the different phenotype concerning vasomotor symptoms or flashes was associated with a reduction in the percentage of survival. The higher the level of hot flashes, the higher the risk, although there was a difference here, as you see, that when the onset of hot flashes was late, at age later than 40 in 121 women, the response was different for any reason which is not absolutely clear as yet. So we have completed the second part of the talks, and let's move now to the third part, which go directly to examine what we have learned concerning studies which have assessed not only hot flashes or the presence of absence of imaging data concerning atherosclerosis, but which has been the impact of estrogens. And we have two types of studies. One in which women were assessed for estrogens, for the level of estrogens in blood, even if they were postmenopausal. We know that postmenopausal women have very low levels, but still they have a certain level of estrogens. And if we use a very accurate method, very sensitive methods for measuring estradiol, which are different immunomethods or also more sophisticated methods, you may differentiate between levels of estrogens even if all women are postmenopausal. This is a cohort, subcohort of the Swan study, 483 middle-aged women, in which again the objective was to measure IMT, intima media thickness. And women were stratified here by quintiles concerning the levels of circulating estrogens. And you see here lower than 14 picograms per ml, and then increasing, progressively increasing the circulating level of estrogens was clearly associated. The higher the level, the lower the size of the IMT, of the intima media thickness. This was a cross study, which again from the same group, and again the Swan subcohort, one subcohort from Swan, in this case 249 women, in which this is not a cross-sectional study, which was a longitudinal study in which women were followed for 3.7 years, and it was shown by these investigators that curiously it is this phase. Women were divided into premenopausal stage, early perimenopausal, late perimenopausal, or postmenopausal stage. And what investigators were measuring was the progression rate of the intima media thickness. And it was mentioned, it was worth mentioning, that it is particularly this period of late perimenopausal stage which seems to be particularly important concerning changes, the progression of IMT associated with the loss of estrogens. This is a very important study. We have been commenting about circulating levels of estrogen, but this is an intervention study. This is the ELITE study, in which 643 women were randomized to estrogens of placebo, and they were divided into two groups depending on the years since menopause. Here, this is women, the early menopause, in which women were living less than 6 years after menopause, or late menopause, in which women were living 10 or more years after menopause. And again, carotid intima media thickness was measured in millimeters here. And women were followed for a series of years. Actually, they were followed for almost 6 years, as shown here in the x-axis. And the interesting finding was that when comparing early postmenopause, which is here the red and the blue line, dotted and dashed lines, there is a difference in women subjected to placebo, which proceed increasing the IMT, while women treated with estradiol, remember that we are at the early postmenopause group, women treated with estradiol, as I said, there were, again, they were increasing the IMT, but they were increasing less than women being treated with placebo. This was not reproduced for any reason for women who were already in late postmenopause. So again, you know that the line of our discourse has been that there is an important period in women in the early postmenopause in which arteries seem to be healthier, still healthier than when they are older. And these healthy arteries seem to respond to estrogens, as shown in this study, or to show changes which are different and which further support that window hypothesis. Again, and now we move back to the WHI because a subcohort of that study, this is the WHI only estrogen arm, and referring only to women between 50 and 59 years, a total of 1,064 women, which were assessed for the CAC, the coronary artery calcium score, by computed tomography, depending on estrogens, if they were treated with estrogen or placebo. And you have here two columns, conjugated equine estrogens or placebo, the intention to treat analysis, or here analysis restricted to participants with 80 or more than 80% adherence to estrogen medication. And it's shown very clear here that the values for conjugates of estrogens and for placebo, look here at the odds ratio, is clear that the number of women with 300 or more, 100 to 300, 10 to 100, there is a progression. The number of women treated with estrogens that exposed or had those high score levels of calcium were much lower in women, as I say, who were treated with estrogens. And this is reproduced even clearer for women who were highly adherent to treatment, because you see that, again, if you check here, for example, the odds ratio for women treated with estrogen concerning the identification of higher than 300 for CAC is 0.61, while it is 0.48 for women who were highly adherent. And this is again reproduced here in this picture, in which is clear again that intention to treat group with adherence, the multivariate odds ratio for the calcium score, here the neutral point, and the higher the protection for those receiving estrogens and for those who were highly adherent to estrogens. This is my last slide, just to give you another message. This is an interesting study which was published in Finland by the group of Olavili Korkala, Tomi Mikola, Paulina Tomorski, who have been very, very active in the investigation of the impact of estrogens on cardiovascular disease. And this is data, whole population data. See, 332,000 women, Finnish women, who were exposed to hormone therapy between 1994 and 2009. And what investigators were checking was the deaths associated with the discontinuation of treatment. So remember that we have been presenting data supporting the value of estrogens as protection against cardiovascular disease. And this is the other way of the story. This is just the other side, in which is the impact of interrupting the estrogens hormone therapy. You see here the risk for cardiac death in those who were lower than 60 years or 60 or more years. And again, you see how the standardized mortality ratio, the SMR shown here, and the confidence intervals is increases when people discontinue taking hormone therapy. This is for myocardial infarction or cardiac death in general, and this is for stroke death in general, which reproduces again the same finding. So again, it seems that women get protection if they maintain hormone therapy, if they maintain estrogens while living the early years post-menopause, and then this may take into problems if they abandon. So this is a warning about those proposals that sometimes women receive concerning discontinuation of hormone therapy. Again, this is the same data, but exposed in a different form. So, in conclusion, as you see, we have analyzed three areas of interest. Firstly, we have analyzed what we learned from the WHI concerning the possibility of the window hypothesis. Then we have examined how new tools, as for example, the imaging tools concerning the direct evaluation of atherosclerosis at the level of the carotid of the coronary tree might be of help, and they are being used in modern studies concerning and supporting the window hypothesis. Again, the hot flashes, the clinical side of symptoms, how they may reflect also, and they may show that there is an association with risk. And finally, we have investigated and shown data that how the use of pharmacotherapy may have an impact concerning those magnitudes, those indicators of atherosclerosis, which are also helpful and further support the idea of the window hypothesis, which is gaining and gaining more and more momentum. So I don't want to finish this talk without reminding you that next year, Berlin, Germany, in May, between the 15th and 17th of May 2019, we will have our 12th European Congress of Menopause and Andropause. So please make a hole in your agenda and consider yourself invited to come to us in this important event, which we celebrate every 2 years, as you know. Thank you.
All right, thank you so much, Dr. Cano. So I would like to mention again that we are encouraging you to submit your questions. We still have a few minutes before we wrap up the session. So if you have any questions related to the presentations, please feel free to type in your questions as we are still running today. Okay, do we have any questions here? Okay, Dr. Cano, maybe do you have anything else to share for the audience while we're waiting for the questions?
Well, yeah, I think this is something, the topic of today is something which reflects the areas in which research is being more active nowadays concerning the impact of hormones, the impact of menopause, and how that apparent paradox that we found when we confronted the data we had mainly from experimental studies, but also clinical studies, observational studies, which were showing a benefit of hormones after menopause for women concerning cardiovascular risk. Finally, there was that paradox of the data from the WHI, in which one of the reasons for advising the discontinuation of hormone therapy to women related with the cardiovascular risk, which was shown by those studies. So these years have been very fruitful in data, in showing and addressing this issue of the window hypothesis. And I think that more and more we are getting there. I mean, we are showing that by imaging studies, by clinical and by, well, even those clinical studies showing clinical events like myocardial infarction or strokes and so on, we can further and further support the idea of the window hypothesis, which I think is very positive and which I think is very helpful in clinical practice, because obviously this changes totally the view that we have concerning hormone therapy in those early stages of postmenopause. So this is a little bit the main message of today's presentation, and I think it's something that most probably in the coming years will add more and more in that area of such a huge interest.
All right. Okay, so I think maybe everybody is shy to ask questions. If there is no questions, should we wrap up this webinar? All right. Yeah. Okay, so I think we should end this webinar as we're running out of time. Thank you so much, everybody, for joining our webinar. This concludes the presentation and the webinar. Thank you so much for your presentation, Dr. Cano, and all the attendees for being here today. And just a quick reminder, you will receive a brief survey that pop up when I end the webinar, and we appreciate your response. Thank you so much and have a great rest of the day. Thank you, Dr. Cano.
Thank you, Anindia. Have a very good rest of the day. Thank you.
You too. Bye-bye.
Bye.